Okay, so thank you very much for the introduction and the invitation to give you what I'm planning a whistle-stop tour of what we know so far about pediatric inflammatory multisystem syndrome temporally associated with SARS-CoV-2, slightly long-winded way of saying it, but has an acronym PIMS-TS that we're using for the time being, or if you're from the US or elsewhere in the world outside Europe, they're using an acronym MIS-C, which is Multisystem Inflammatory Syndrome in children. The talk, I'm going to give you some basics at the beginning just to get everyone up to speed. I'll do a revision of what Kawasaki disease is for those that maybe aren't so seeing cases regularly. I'll talk about what we saw with COVID in the early weeks and how we identified PIMS-TS. Some comparisons to Kawasaki disease and toxic shock, and some of the accumulating literature, and then some theories about what's going on and what's going to happen next. And every time I do a talk on this, I update my calendar of the months that have gone by since the start of the pandemic, just to remind us that although it feels a very long time, it's still very early in our knowledge of this disease. And so I won't go into the virology in detail, but SARS-CoV-2 is a coronavirus that is related to previous severe coronavirus infections like MERS and SARS. And we diagnose it through a combination of history, examination and investigations, and if you've got a contact history or epidemiological risk factor, alongside results of PCR testing.
You muted yourself, Alasdair.
Oh, okay. Sorry about that. I don't know how long I was muted for, but serology is another means of testing for past infection. There's a characteristic blood profile, which I'll talk about later, and there's characteristic findings on various formats of imaging that you can use as a clue as well. Kawasaki disease, some of you, the majority of you are probably familiar with this, but just a reminder that this is a childhood illness that's characterized in the classic form by 5 days of fever, along with 4 out of 5 of mouth and lip changes such as erythema, conjunctivitis, erythematous rash, changes of the hands and feet, and cervical lymphadenopathy. And that's a disease we've known about for some time, but still don't have a diagnostic test for, and that we don't know what causes it. To make things a bit more confusing, we have incomplete Kawasaki disease, and this pathways by the American Heart Association gives you some diagnostic pathways for diagnosing it, but it is quite confusing how to diagnose incomplete Kawasaki disease, and sometimes a bit more of an art than a science. But in common with classic Kawasaki disease, the management is mainstay is IVIG and aspirin, with or without high-dose aspirin or infliximab in treatment-resistant cases. And the main outcome we're trying to avoid in Kawasaki disease is coronary artery aneurysms, which is the most severe a type of outcome that can be associated with even mortality in rare cases. There's a rare form of Kawasaki disease that's associated with shock in a small proportion of children, and it's good to remember that when we're thinking about the presentation of PIMS-TS. So what were we seeing in the early weeks? Well, we thought that we were going to escape as paediatricians from the main problems of COVID in terms of disease, and the ASARIC project published these rapid reports, which just did show that in the UK the impact of the disease in the paediatric age range was very small. It also gave us some information on the risk factors for severe disease in adults, such as cardiac disease, hypertension, neurological disorders, asthma, but these didn't seem to be consistent with the risk factors that we were seeing in data published from children in areas affected before us. So with data from China, Spain, Italy, the States, we were expecting low numbers of cases of COVID in children, relatively mild asymptomatic disease infection, very rare to have severe illness, and the blood picture wasn't going to, we didn't think it would be like what we see in COVID, severe COVID in adults, and we spent most of our time scratching our heads and thinking, why is it that children are escaping? We had some useful data from the RCPCH, which was accumulated in real time with voluntary reporting, which just showed that the majority of children hospitalized with COVID actually had no comorbidities, but some pattern did come out of a problem such as chronic respiratory illness, neurological illness, and oncological diagnosis as possible risk factors in children, but there's very small numbers to conclude anything. The children admitted with COVID seem to have a similar pattern to adults, with fever, cough, lethargy, coryza, and shortness of breath. So the few children that did get COVID seem to be similar to adults in the early days, but very few of them required extensive ventilatory support, with very few requiring ventilation or HDU or ICU. And lots of rapid case reports and meta-analysis and systematic reviews came up, all discussing this and showing that it was a mild disease. And why was this? We had a survey within the PTBnet, which was a network across Europe set up to monitor TB, but actually converted quickly to working with COVID. We surveyed their members and found that, again, that children had relatively mild course. There was a trend towards the severe presentation being mainly in adolescents or very young children, but there weren't really any big risk factors that came out, and very few deaths in that study. So we pontificating about why is it less severe. Was it to do with the young child's immune system, a difference in their Th1, Th2 balance of immunity compared to adults, or is it to do with the fact that they get exposed to lots of other viruses in early life? Do they have a different and more healthier blood vessels at the point of infection? And is there differences of expression of receptors for cell entry for SARS-CoV-2? But nothing really has been proven yet in relationship to this, and there's lots of questions still outstanding. You'll be familiar with diagrams like this about the progression of COVID in adults, and the theory being that you have an early viral stage followed by an inflammatory stage later on, which is the severe and not fatal part of the disease. And the older you are, the more likely you are to progress to this sort of severe hyperinflammatory type of disease, with children presumed to escape this for some reason. And then you'll just see in this model from this paper that they have suggested that the MIC or PIMS-TS is a late manifestation of this hyperinflammation. Whether it's the same as that seen in adults or not is yet to be determined. So why might children have less severe primary COVID infection? Well, there's theories about this, but the model in adults is that you get viral infection primarily through the route of the lungs, and you have two outcomes. One is that you have an appropriate immune response with innate and acquired immunity leading to clearance of the virus, or everything gets a bit out of control and altered an uncontrolled immune response to the virus, which is self-perpetuating, leading to sort of cytokine storm and widespread inflammation and organ damage. And for some reason, children are escaping this bit in the acute phase. And theories about why this might be, as I've already mentioned, is difference in expression of receptors for cell entry of the virus, but also difference in the sort of immune milieu within the lungs, with different balances of anti-inflammatory cytokines, and also, as I said, sort of a postulation. It's postulated that the endovascular endothelial layer is healthier or different to that of older adults, and there's a lot of data coming through that vascular injury is an important part of severe COVID in adults, at least. So we were thinking about all of this, and then suddenly May came, and it's definitely a May to remember for paediatricians across the UK, where there's. I'll tell the story of the emergence of PIMS on the background of cases in London. This curve is the positive PCR proven SARS-CoV-2 in adults in the London region, starting off in sort of early March, with peak rise in cases around early April. This is when WHO just declared the pandemic. And then a couple of months later was when we had this memorable weekend where there were cases arising across London, being retrieved by cats and STRS, of children with shock, multisystem inflammation, no evidence of SARS-CoV-2 PCR positivity, but severe disease, and it was enough to cause us to call an urgent meeting with NHS England and the RCPCH, and an alert was launched by the Paediatric Intensive Care Society followed rapidly by a group of us within the RCPCH who work with clinicians around the country to look at the first 37 cases that we accumulated to try and characterize and define this condition further. We had to come up with a name, and unfortunately we came up with this name, which is terrible, I think, but it had to do. But and just to explain, we didn't know at this stage that it was related to SARS-CoV-2. Definitely, it could have been another infection or another inflammatory condition that has nothing to do with SARS-CoV-2. So we had to be cautious in our labeling of it and just say that the condition arose at the same time as SARS-CoV-2. And the case definition, which I'll show you in a minute, the purpose of it was not was to be broad, to catch as many cases as possible, to be able to catch cases of other diseases such as Kawasaki disease, rheumatic fever, or macrophage activation that may be triggered by SARS-CoV-2, to inform surveillance programs that were rapidly implemented, and to raise awareness and guide clinicians about how and when to refer. And just to stress, it wasn't defined as designed to be the definitive definition of this condition, and it was not to be dependent on the diagnosis of SARS-CoV-2 infection, because, as I said, we didn't know, and I still don't think we've definitively proven that it is all due to SARS-CoV-2. So there's the case definition. I won't go through it in detail, but as I said, multi-system inflammation, sometimes associated with shock and multi-organ dysfunction, exclusion of other causes, and PCR positive or negative on SARS-CoV-2. And as I said, we looked through a series of 37 cases to begin with, and we looked at common features amongst them and tried to think how they may be similar or different to existing conditions such as toxic shock and Kawasaki disease. What these cases had in common were fever, rash, conjunctivitis, abdominal symptoms, and headache. And then clinically, they were presenting with shock, myocardial dysfunction, ECG abnormalities, a minority with coronary artery dilatation, and a subset with bowel inflammation as well. And this is what made us really think that this was associated with SARS-CoV-2, because the blood picture was very similar to severe COVID in adults, with low lymphocytes, very high inflammatory markers, high D-dimers, and raised troponin and pro-BNP. So clues that it was related to SARS-CoV-2. But as I said, the minority were PCR positive. But as we got more and more results from the serology coming back, the majority were IgG positive. In that first early week, sort of the first week of May, a couple of publications came out, one from the Evelina with the first 8 cases that were retrieved to their PICU. And in the same week, we had a series of 8 children with unexplained abdominal symptoms that thought to have been triggered by SARS-CoV-2, but without evidence of PCR positivity from GOSH as well. So children with a sort of acute abdomen presentation. A week or so later, the cases started to arrive in the States, and the CDC published their case definition, which goes to a slightly higher age range, similar to the RCPCH definition, but with more of a dependence on having proven SARS-CoV-2 or a recent epidemiological risk factor for it. And the ECDC published a rapid report the next day. And then the WHO published their case definition, which is very similar to the US definition a few days later. So lots of definitions, and all very similar but slightly different. We extended this initial series of 37 patients to 58 patients and looked at them in detail with Mike Levine and his team, and compared them with historic case series of children with Kawasaki shock, toxic shock syndrome, and then compared them in terms of clinical presentation and laboratory parameters to see if there are similarities and differences. Without going into too much detail, you can see this is the comparison with KD shock and toxic shock syndrome. You can see the PIMS patients were older. They had slightly higher neutrophil counts than the KD and KD shock. Lower lymphocyte counts as seen in COVID. They tended to be more anemic with lower platelets than the other conditions. Looking at other blood parameters, something that was really characteristic was extremely high CRPs, low albumin, very high ferritin, almost in the macrophage activation range, raised troponins, raised pro-BNP, and raised D-dimers. So it does seem to be something slightly from this limited report that it's a different entity from conditions we know about. And this final slide of the epidemiological curve just shows us the temporal relationship. And in this first, if I can go back, this first arrow, when we looked back in retrospect, this was probably when we had our first case at GOSH. and that was about at the peak of cases within the London region. So and then as cases went down in the UK of COVID, then the numbers of PIMS started going up. So we had our peak of PIMS in GOSH about a month later. So there's a temporal relationship, and then they died away a month later than when COVID died away. So all clues that it's related. After this, there was a lot of rapid publications that came out looking at characterizing further the multi-system involvement of the disease. This is a report from Birmingham where they looked at a small cohort of patients with cardiac involvement, the majority of them requiring intensive care for respiratory or inotropic requirements. And they noted that there was commonly gastric involvement as well, with raised cardiac markers and a range of cardiac abnormalities. They highlighted that they were mainly treated with IVIG and steroids and had very short follow-up periods, so not much about outcome. We haven't published yet from GOSH, but speaking to Philip Kuchera, who's leading on our cohort at GOSH at the moment, we've now got data out to about 6 months now, and children do seem to be recovering very well, even despite quite significant cardiac dysfunction in a subset of them. And a small minority have persisting coronary artery dilatation. In terms of neurological involvement, this is a small series from GOSH, which was published early on, which just showed that there was a subset of PIMS patients that had neurological involvement, a mixed central and peripheral nervous system involvement, and a characteristic change in the splenium of the corpus callosum on MRI. Again, this is an early report with limited follow-up data, but 2 out of 4 had fully recovered by the time of the report. And we postulate some mechanisms in the paper, but there's no data yet to know what they are. Another series from the cohort from GOSH here, from the renal team this time, alongside the PICU team, which looked at 52 of our patients with COVID. So this includes COVID disease as well as PIMS-TS. They looked at the rates of acute kidney injury, and they showed that this was quite common in both COVID and PIMS-TS, but tended to be more common in the PIMS-TS cohort. And if you got to PICU with COVID or PIMS-TS, then you were very likely to have AKI. None of the children required renal replacement therapy, and all of them got better, and the mechanism was proposed to be hypovolemia and hyperinflammation. And there's actually a larger UK case series of PIMS-TS and renal outcomes that's been published since. In terms of imaging, this is a nice series that came out of the Evelina, looking at the imaging in their cohort that is similarly of a similar size to our GOSH cohort, showing that chest X-ray and chest CT findings are not particularly characteristic and quite often normal. They showed some coronary artery dilatation on cardiac CT, and interestingly on abdominal ultrasound, and this is a common theme across centres, is that there's right iliac fossa inflammation that can be confused with appendicitis, terminal ileitis, and a subset will also have colitis as well. So it does seem to be affecting a specific part of the bowel in terms of inflammation. And CT didn't really add anything to what was seen on ultrasound. So that was the UK cohort that was published rapidly. France also were publishing in parallel, and this is just to show that they had epidemiological studies that showed this pattern of the peak in COVID in adults, followed by a month later by the peak in PIMS in children in France. And this is just the geographical distribution, which mirrors the COVID. The PIMS mirrors the COVID. And then the States, this is all due to the progression of the pandemic across the world, but then they started to see their cases and rapidly accumulated case series across the States. This is New York State, and then across the US with the CDC. And again, you'll see this familiar pattern now of the rates of COVID followed by the rates of PIMS, or MIS-C as it's called in the States. So very, very recurrent theme that it comes a month later. Going back to the UK now, and this is a nice study from the PICU group, where all the PICUs across the UK grouped together to publish on 78 patients. They have shown that the majority of PICU patients with PIMS were male. There was a preponderance for male sex, and the age range was the same as in all the other case series, with an average of about 11 years of age. There was a tendency towards obesity and overrepresentation of Afro-Caribbean and Asian ethnicity. A minority were PCR positive, and the majority were serology positive. There was not co-infection in the majority of cases. There wasn't any co-infection, I mean, and they had in common fever, shock, abdominal symptoms and rash. And this nice graph just shows the expected cases of hyperinflamed children, be that from macrophage activation or severe Kawasaki toxic shock that you would see in a given time period, plotted compared to the PIMS. So this is over and above what we see in this time period for hyperinflamed children. That was the blood picture from the PICU study, which wasn't particularly different from what has been observed in other case series. And this is just a nice graph that they have also published, which is looking at the treatments. And this is probably what this audience is wanting to talk about, which is the increasing use of intravenous immunoglobulin over the course of the emergence of PIMS-TS. And as cases came along, we started using antiplatelets agents as well in view of the coronary artery dilatation that was being observed. Steroids was also employed, and biologics started to be used towards the end of the surge of cases. So what's happening? I think, hand on heart, I don't think anyone knows still. I think we've got a lot of theories, but there's no real hard evidence for what's happening here. I'll go back to this diagram of this late onset inflammation compared to adults, and we can think about whether this is the same type of hyperinflammation observed in severe COVID in adults or not. And there is some observational data looking at that I'll summarize in a bit. There is one group that has postulated that it is a superantigenic type of process and similar to toxic shock syndrome, and suggested that there's certain polymorphisms of the COVID virus that would act in a superantigenic way and trigger this syndrome. Judith Brewer, who's a virologist at UCL and ICH, who has looked at the virus in our children with PIMS and compared it with circulating community isolates, and not found a difference in the range of viruses that are observed, which would go probably against this theory, but again, small numbers. So wait and see. And this is a very nice paper from the Evelina group alongside the King's team, where they've looked at their cohort of 25 patients compared to 7 healthy controls and looked at 3 time points at very detailed immunophenotyping. I'm not going to go into great detail, but just to highlight that the serology showed that the majority were IgG positive with low levels of IgM, suggesting infection happened at least sort of 2 to 3 weeks prior to the presentation. They've looked at in detail immunophenotyping of innate T and B cell phenotype, and they've confirmed the lymphopenia, but also looked in more detail and showed characteristic immune activation and impaired antigen presentation, which may or may not be relevant to the pathogenesis. They've looked at a panel of cytokines and have shown that the range of cytokines are raised within PIMS-TS, and we have similar data from Gosh that's yet to be published showing that IL-6 and IL-10 are particularly raised in this cohort. And they have also looked at the immunophenotype and looked at historic data from Kawasaki suggesting that it's very different. And these graphs on the right here just show that the healthy controls on the left, this is immunophenotype, and you can see that it's very abnormal compared to controls at baseline and gradually recovers over time at 3 time points, at the 3rd time point being at clinical recovery. Another group that's looked very nicely at the immune phenotype in detail and also compared to Kawasaki disease, healthy controls, children with SARS-CoV-2 and also adults with severe COVID. So a slightly more in-depth look at direct comparisons. They have, it's a collaboration between Italian group and Swedish group. The first interesting piece of data is where they've looked at principal component analysis to compare MIS-C with or PIMS with adult severe COVID, and through this they've shown that the proteins that are circulating are very different from those of severe COVID in adults, suggesting it is a different entity probably. Again, I'm not going to go into too much detail about the immune phenotyping, but we can go back to the slides if anyone is particularly interested later in the talk. But the immune, this is just to highlight that they looked at healthy controls, children with COVID, children with MIS-C and Kawasaki disease, and compared immune phenotype across CD4 T cells and shown that they do seem to have a unique phenotype. Again, they've looked at cytokines similar to the Evelina King's group and shown that there's a characteristic pattern of cytokine expression which is distinct from Kawasaki disease, and children that just have COVID but not PIMS-TS. And this is the first interesting, I think, bit of data about thinking about possible mechanisms, in that they looked at a range of antibodies to common cold viruses and other viruses, and they found that MIS-C patients had actually lower levels of antibodies compared to at presentation to common cold viruses compared to the Kawasaki disease patients. The meaning of this is not clear at the moment, and it could be just that they're older and they have less of these antibodies around, but it's interesting to think that maybe antigenic exposure or recent antigenic exposure to other viruses may be implicated in the pathogenesis. They also looked at a huge range of candidate autoantibodies, which they did identify within both Kawasaki disease and MIS-C, and they've shown that they're distinct for the two conditions, but as such, this is just observational data and it needs further investigation. But autoantibodies are obviously of great interest in the adult literature, from the severe COVID and anti-interferon antibody story coming out of the Casanova lab, so watch this space. And just drawing to an end now, this is a lovely, very in-depth case series from the US, where they have 570 patients published from the USA. They have used a technique called latent class analysis to split the cases that were reported as MIS-C into three groups that cluster. And it's similar sort of anecdotally to what we've observed in the UK, that there's children that are sort of a pure, what you'd say, PIMS or pure MIS-C, which are just multi-system inflammation with characteristic bloods and shock and cardiac dysfunction, with not much overlap with KD or other or acute COVID. And then they found acute COVID, which had with hyperinflammation, with ARDS and respiratory presentation, which would be more like your classic adult type of COVID, but similar blood picture. And then there was another group of younger children that were much more like KD or partial Kawasaki disease. And so there does seem to be distinct groups within these cohorts that are being reported, and we need to be really careful that we're working out which ones are COVID, which ones are KD, which ones are MIS-C, and how much they overlap or not. And ISARIC will be publishing, I think, in the near future, similar analysis from their cohort of children in the UK with PIMS-TS, with similar results. So where does this leave us? We've got PIMS-TS, MIS-C, COVID, and Kawasaki disease. Well, just taking a step back, I just maintain that the Bradford Hill criteria for proving that SARS-CoV-2 causes this condition in all cases is still not fulfilled, and we need to just remember that and keep that in mind when we're publishing and looking at the data. It would be lovely to have a really large case control study or prospective studies looking at kids that get COVID and then which ones get PIMS-TS later, but they've not been possible yet. And I'm trying to think of a sort of good analogy, and it's a bit of a work in progress, so forgive me, it's a bit clumsy at the moment. But my thought is that you have a kid will have exposure to SARS-CoV-2, and for some reason most of them don't get any inflammation associated with it and escape symptom-free. A small proportion will get COVID and after a very short time period progress to hyperinflammation, and that tends to be the older adolescents that seem to be more similar to adults in a lot of ways. And then the spark is the fuse is lit, and it remains quite quiet for a long time, and then for some reason 4 or so weeks later, kids progress to either a PIMS-TS type phenotype or they get Kawasaki disease. And we know that lots of viruses are associated with triggering Kawasaki disease, so why SARS-CoV-2 should be any different, I don't think it should be. So there'll definitely be some KD triggered or associated with SARS-CoV-2, and we'll have PIMS-TS, and there may well be overlap between the two, but it's difficult to know how much there is overlap. In terms of management, it's difficult because it's an evidence-free zone. We have data on management of similar conditions such as toxic shock, myocarditis, and KD that we can extrapolate from, but we just really don't know. We went through the Delphi process, which was an amazing piece of work from NHS England and RCPCH, with I think around 90 professionals in many different disciplines coming together to answer many questions over and over and over again until we got consensus or not on various approaches. And this is a nice paper just to look at in terms of how we think about management processes prophylaxis, the clinical management, and when we think IVIG may be appropriate, or steroids, biologics, aspirin and thromboprophylaxis, but very much an emphasis overall that children, as many children as possible, should be in research trials. And the recovery trial, which you're all probably familiar with, has now been tailored to allow children to enter into it with a randomization to IVIG versus steroids versus standard of care, with a second randomization to tocilizumab versus standard of care. So watch this space in the second wave, which I'm sure is on its way. And then just finishing, just to stress that it's very rare. I think the seroprevalence, I haven't seen more data subsequent to this, so apologies if anyone knows any more data to this, but it's thought to about 5% of kids have been infected in the UK so far. So that's huge numbers of children. And if you think that only 75 children have been to ICU and around, I think it's about 300, 400 in the BPSU survey, it's a very rare condition. So to remember that when communicating the health messages to the public in general. And this is just a nice paper which looks at rates of death in a similar time period due to other causes in the UK and in other regions of the world, which just shows that rates of death from unintentional injury, respiratory tract infections in general, and flu are higher in general than the deaths we've had from COVID or PIMS-TS in the UK. So very, very rare for children to get very sick. My take-home message to all the doctors that I'm talking to about this is not to miss other differentials and not to get fixated on PIMS and COVID when you've got a child with PUO. I'd hate for a child to be missed with bacterial sepsis, a severe fungal infection, disseminated HSV, or a malignancy, having been treated with steroids or IVIG, thinking that this is PIMS-TS. We've got lots of unknowns. You can probably conclude all of these lines from the talk that I've just given, but the studies from BPSU, Diamonds, Genomic, Recovery, and ISARIC are all trying to rapidly answer questions relating to this condition, and we'll hopefully have some publications in the near future. Just to finish, if we've got some adult physicians in the audience or people that look after adults, then it is coming in young adults as well. And there's 2 case reports of adult PIMS, and in the US they're calling it Miss A, Miss C instead of Miss C. It's Miss A that they're now calling it in terms of presentation in adults. And my final slide is we really need a better name and a unified diagnostic criteria in order to treat these children. So if anyone can think of one, please let me know, and I'll try and feed it back to the people that make that type of decision. So that's it. I hope I've covered most of the things that you were hoping for me to cover. I think my last line there is what's next. I think that if we have a similar thing happen to last time, then we'll probably get a peak of PIMS in around December time. So look out for, be aware of that, and expect there to be cases being discussed at that time. It's an amazing collaborative effort from lots of groups still ongoing relating to this, and hopefully we can learn together about how to manage and keep children well and safe.